Evaluation of our post-appendectomy management protocol. Ashraf Abdulhamid Ibrahim, Talal Isam Reyes, Tariq O. Abbas, Shima A. Al Romehai, Mansour Ahmed Ali. Introduction. Acute appendicitis being the most common emergency condition in pediatric surgery, there appears to have no consistency on the management protocol. Numerous researchers sought to find the most effective outcome with the least morbidity rate using various diagnostic algorithms and different antibiotics. Many protocols had been created and modified, but none were aspiring to be the best in pediatric surgery. In 2008, Sean et al. Standardized the definition of perforated appendix to be only when you see a hole in the appendix or a fecalith in the peritoneal cavity. Their outcome was improved after the application of the definition of perforation, but not to a great extent that we decided to extend the definition and set a treatment protocol accordingly. Various surgeons decided on the duration of post-appendectomy antibiotics based purely on the clinical findings. In turn, they stopped the antibiotics and discharged patients home when the child was afebrile, able to tolerate feeding and pass a bowel motion. Their decisions led to the flaring up of post-appendectomy infections due to inadequate treatment in some cases. Because there was no agreement about the appendicitis treatment, we tried to hold onto these cases early on before they were discharged to avoid potential future complications. In 2012, Holcomb and Sean studied optimal antibiotic regimen and the length of antibiotic therapy. In 2015, Farrick et al. Published a study in which they found that operative findings are a better predictor of resource utilization in pediatric appendicitis, and this aligns with our protocol, which employed more precautions in order not to miss early post-appendectomy abscess formation. Objective. We analyzed the management outcome in 2 post-appendectomy groups retrospectively before and after the implementation of our treatment protocol according to the new intraoperative appendicitis definitions, regarding primary objectives, which are length of hospital stay, LHS, days, and the incidence of post-appendectomy abscess formation. Additionally, we aim to identify other variables like the incidence of wound infections, readmissions within the first month after the initial appendectomy, and the in-hospital intravenous antibiotic charges, US dollars. Methods. The study was conducted with the permission of the Medical Research Center HMC Ethics Committee. Date: October 8, 2021. Decision No. MRC 01-21-446. All procedures were carried out in accordance with the ethical rules and the principles of the Declaration of Helsinki. We used a retrospective cohort study. Our age group is 0 to 14 years old. All cases were done by laparoscopy, and the converted cases are not included in the study. C-reactive protein, CRP, and CBC are being done as a routine blood tests for all the cases with abdominal pain in the emergency department as a baseline before admission to the hospital. We studied the post-appendectomy treatment before and after the application of our design treatment protocol, which was applied in 2012. We created 2 groups, one before and one after 2012. We avoided the year 2012 because of the overlap period. The sample size was calculated with the help of our Medical Research Center, MRC. The sample size collection identified the required number would be 89 patients to identify statistical significance. Nevertheless, we collected 100 patients in each group. Our MRC statistician based the sample size calculation on Sean et al. Study. The sample size was determined on the primary outcome variable length of stay days, reported in the literature, with effect size 1.2, standard deviation of the change in the outcome 3.5, statistical power 90% and level of significance 5%, the required sample size would be n equals 89 cases. However, to account for multiple secondary outcome measures such as dropouts and non-responses, it was good to increase an additional 30% in the calculated sample size, i.e., a total of 200 participants divided equally into 2 groups will be included in this study. The following sample size equation was used. The standard normal deviate for alpha equals z alpha equals 1.960. The standard normal deviate for beta equals z beta equals 1.282, A equals 1.000, B sad face z alpha plus z beta, 2 equals 10.507, C sad face E/S, delta, 2 equals 0.118, AB/C equals 89.39, group size N, 89. In the first group, post-appendectomy treatment including antibiotics duration was empirical and it differed between each surgeon. It was dependent on the clinical picture, presence of fever, tolerance of feeding, abdominal pain, and presence of diarrhea. The protocol of Group 2 is guided by the preoperative white cell count, WBC, CRP, and intraoperative classification. Our antibiotic regimen adheres to our local institution of infection control guideline standards. The first-line antibiotics are ceftriaxone and metronidazole, the duration of which was established by our intraoperative new classification. In the second group, our new protocol strictly classified appendicitis into 3 categories: normal and inflamed, severely inflamed and perforated according to the intraoperative findings. Normal appendix meant the peritoneal cavity is clean and no local signs of inflammation in the appendix. Just inflamed appendix meant the peritoneal cavity is clean and the inflammation was confined to the appendix only. These patients received a single dose of antibiotics upon induction of anesthesia. Severely inflamed meant inflamed appendix with the presence of pyogenic membranes or pus. These patients received 3 days of antibiotics starting upon induction of anesthesia, and before discharge we repeated the CRP and WBCs, then we followed up according to the CRP and WBCs results. The perforated appendix meant inflamed appendix with the presence of a hole in the appendix or a fecalith in the peritoneal cavity. These patients received 5 days of antibiotics starting upon induction of anesthesia. Before discharge, morning of the 6th postoperative day, we repeated the CRP and WBCs, then we followed according to the CRP and WBCs results. A total of 200 patients were collected, 100 patients before applying the treatment protocol, Group 1, and 100 patients after employing the protocol, Group 2. The number of males was 140, 66 in the first group and 74 in the second group, total being 70%, while the females were 60, 34 in the first group and 26 in the second group, total being 30%. The total number of post-operative intra-abdominal collections, abscess formation, is 9, where there were 5 in the first group and 4 in the second group. There was no significant statistical difference between Group 1 and Group 2 as regard the risk of developing a post-appendectomy intra-abdominal collection, p equals 0.733 or equals 0.792, 95% CI 0.206 to 3.039. Regarding the LOS, Group 1 had shorter mean length of hospital stay than Group 2, 4.57 versus 5.3 days. The one-sided t-test showed a marginally significant statistical difference between the two groups, 0.73 days, 95% CI, 1.6 to 0.14, p equals 0.05. Regarding the antibiotic charge, Group 1 had a lower mean antibiotic charge compared to the Group 2, 180.96 versus $228.06. The one-sided t-test showed a marginally significant statistical difference between the two groups, $47.10, 95% CI, 97.74 to 3.54. Finally, hospital readmission was 1 in the first group and none in the second group. Discussion. Although acute appendicitis is the most frequent emergency condition in pediatric surgery, unfortunately, there is no standard protocol for its management. Surgeons around the world classify patients with complicated appendicitis using a variety of criteria and categories. The absence of a standardized definition of perforated appendicitis is responsible for the large variation in reported perforation rates and discrepancies in postoperative abscess rates among individuals with perforated appendicitis. Surgeons use terms such as purulent, perforated, gangrenous, necrotic, ruptured, contained perforated, and degrees of peritonitis for which there is no evidence. Additionally, they represent the same entity. Recent research on this subject revealed a dramatic spectrum for perforation, ranging from 20% to 76%. Furthermore, several surgeons make these diagnoses based on their general clinical impressions, as opposed to the objective criteria. American Pediatric Surgical Association, APSA members were surveyed in 2000, and the majority reported basing their practice approaches on personal preferences. Exercising various diagnostic algorithms and antibiotics, numerous researchers attempted to discover the optimal method for achieving a favorable outcome with minimal morbidity. Numerous protocols had been developed and modified, but none stood out as the most effective in pediatric surgery. In 2008, Sean et al. Standardized the definition of a perforated appendix to include only the presence of an appendix perforation or a peritoneal fecalith. Appropriately, we decided to expand the definition and establish a new treatment protocol. Numerous surgeons determined the duration of post-appendectomy antibiotics based solely on clinical findings, so they were discontinuing antibiotics and releasing patients when they were afebrile, and they were able to consume and have bowel motion. In some cases, this led to the worsening of post-appendectomy infections caused by such inadequate treatment. As there was no consensus regarding the treatment of appendicitis, we attempted to identify these cases early to avoid potential complications. In 2012, Holcomb and Sean investigated the optimal antibiotic regimen and duration of treatment. Operative findings are a better predictor of resource utilization in pediatric appendicitis, according to a 2015 study by Farrick et al. This finding aligns with our protocol, which incorporated more precautions so as not to neglect early post-appendectomy abscess formation. Prior to 2012, Nadler et al. Treated perforated appendicitis with a triple antibiotic regimen consisting of ceftriaxone, gentamicin, and metronidazole, triple antibiotics course. However, this regimen demands a complicated dosing schedule and blood tests to monitor nephrotoxic gentamicin levels. Recent research indicates that monotherapy with piperacillin/tazobactam for intra-abdominal infections is as effective as traditional triple therapy. However, individual doses of piperacillin/tazobactam are costly, and patients still require 3 to 4 doses per day. In our institution, we spare this regimen for the resistant organisms or when it comes to the culture and sensitivity studies for the peritoneal fluid aspirated during the appendectomy. During our study, although there was no significant statistical difference between the two groups, there was an important clinical difference which reflected on the patient outcome. In the first group, 5 cases had post-operative abscess formation, 4 of them after complicated appendicitis cases, 2 suppurative and 2 perforated, and 1 after simple inflamed appendicitis, where 1 which was discharged and readmitted again. In the second group, 4 cases had post-operative abscess formation, only 1 after suppurative appendicitis and 3 cases after simple inflamed appendicitis. All of them were picked up before discharge from the hospital. In the second group, none of them got readmitted due to surgical complications. 2 patients were readmitted in this group, 1 due to pneumonia with pleural effusions and the other with nonspecific abdominal pain managed conservatively in general pediatrics after clearance from pediatric surgery. None of the postoperative collections in the second group was discharged home. All were picked up before being discharged and were treated early. Although the percentage of patients with perforated appendix in the second group, 12%, is greater than those in the first group, 5%. Incidence of complications, readmission, and antibiotic cost is near in both groups, which gave advantage to the second group. Conclusion: we recommend the application of our management protocol as it has a clinical significance. Less postoperative complications guiding the antibiotic duration, and we can pick up of post-operative collections before sending the patients to their homes. However, we recommend future prospective larger studies or randomized trials with the use of more sensitive inflammatory markers, like procalcitonin, to enhance the study's impact.